All right. Let's start by understanding the structure of the stomach. And imagine it as a series of zones that food passes through from the esophagus to the small intestine. Um, First, we have the gastroesophageal junction, then the cardia, followed by the fundus and body, the antrum, and finally the pylorus.
So it's like a conveyor belt for food digestion, moving from one zone to another. I'm trying to visualize how each part functions differently.
Exactly. So uh, each zone has specific roles. The cardia, for instance, is where uh, the stomach meets the esophagus and plays a crucial role in preventing acid reflux.
That makes sense. But I'm still unclear about the two types of mucosa mentioned. Antral and oxyntic. How do they differ?
The antral mucosa is more protective, secreting mucus to safeguard the stomach lining, while the oxyntic mucosa is all about secretion, like producing hydrochloric acid and intrinsic factor. It's fascinating how specialized each part is.
So the entire stomach lining is made up of pits and glands beneath them. Can you explain what these do?
So absolutely. Um, the pits are invaginations on the surface, and beneath them lie glands that produce various substances essential for digestion. For example, in the antrum, you'll find glands producing mucus, whereas in the oxyntic region, parietal cells secrete acid. All right, let's dive into the structure of the stomach mucosa. The surface and pits in the stomach are lined by columnar mucinous epithelium, often referred to as foveolar type. These cells stain bright pink when using TASB staining, which highlights their mucinous quality.
So these foveolar cells are responsible for producing mucus. And they make up the surface layer of the stomach lining.
Exactly. So the regions of the stomach are categorized based on the type of underlying glands. Let's talk about two main types. Antral mucosa and oxyntic mucosa.
Wait, I'm getting a bit confused. You mentioned foveolar cells line the surface and pits. Does that mean they're part of both regions?
Great question. The antral mucosa is found at the borders of the stomach, the cardia, antrum, and pyloric regions. In these areas, the glands are loosely packed, mostly mucinous, and occupy about half of the epithelial thickness. That means the other half consists of those bright pink staining pits we discussed earlier.
So in antral regions, it's more about mucus production rather than digestion. Because the glands are less dense and mostly mucinous.
Um, exactly. Now moving on to the oxyntic mucosa, which is found in the fundus and body of the stomach, the digestive regions. Here, the glands are tightly packed, containing two types of cells you should remember, myparietal cells and chief cells.
Parietal cells are pink because they're acid secreting, right? And chief cells are purple due to their enzyme secretion. Got it.
That's correct. In the oxyntic mucosa, these glands occupy 3/4 of the mucosal thickness, making them far more prominent than in the antral regions.
So to summarize, antral mucosa is about borders and mucus, while oxyntic mucosa is about digestion with parietal and chief cells. But the thickness difference makes sense for their functions.
And today we're discussing transitional mucosa and endocrine cells in the stomach. The transitional mucosa is an overlap zone between the antrum and oxyntic areas where features of both are present.
I'm a bit confused about why knowing the type of epithelium is so important here.
Excellent question. The type of epithelium can influence how certain processes affect the mucosa. For instance, some conditions may differentially impact antral versus oxyntic areas, which could change our differential diagnosis.
Got it. So step into their crimes actually both.
We are endocrine with the endocrine cells are scattered in these glands.
Are they all the same throughout the stomach?
No, they vary. In the body of the stomach, we mainly find enterochromaffin-like cells. However, in the antrum, endocrine cells produce various hormones like gastrin, somatostatin, and more ECL-like cells.
I see. How do we identify these cells under a microscope?
Chromogranin stains are helpful as they highlight all endocrine cells. Gastrin stains, on the other hand, should only be positive in the antrum. When conducting a biopsy survey under low power, it's essential to first examine the glandular epithelium, pay attention to the type of mucosa you observe, and compare it with what the endoscopist described.
I'm a bit confused about how to assess the color of the biopsy specimen. Could you clarify that?
Certainly, healthy stomach's mucosa typically appears pale pink. If the tissue looks blue, this often indicates inflammation in the stroma, such as in gastritis cases. On the other hand, if the stroma appears pink with unusually dark and distinct glands, it might suggest chemical gastritis. And this is where understanding the correlation between histological features and clinical observations becomes crucial. Let's discuss the anatomic zones of the stomach and their associated histology, endocrine cells, and common pathologies. And first, let me show you figure 7.1. The stomach is divided into several regions. The esophagus, cardia, body and fundus, antrum, and pylorus. Each has distinct histology and functions.
Could you explain how these regions differ in terms of their histology?
The esophagus has squamous epithelium, and the cardia, antrum, and pylorus have mucinous epithelium, while the body and fundus feature oxyntic mucosa with parietal and chief cells.
What are the common pathologies in each region?
The esophagus is prone to conditions like reflux esophagitis and Barrett's esophagus. The cardia often deals with H. Pylori gastritis, while the antrum is associated with gastrin-related issues.
How does H. pylori affect different regions?
Pylori primarily affects the cardia and antrum, leading to gastritis by producing urease and other virulence factors.
What about the body and fundus?
The body and fundus are linked to autoimmune gastritis involving antiparietal cell antibodies. The pylorus deals with chemical gastritis due to bile reflux.
How does oxyntic mucosa differ from antral type mucosa?
Oxyntic mucosa is thicker with parietal and chief cells for acid and enzyme secretion. Antral mucosa is thinner, involved in hormone production. All right, let's dive into the different types of mucosa in the stomach. One important distinction is between antral type or mucinous mucosa and oxyntic mucosa. The antral type is found in the cardia, antrum, and pylorus.
Wait, I'm a bit confused. Could you explain what makes the antral type mucosa different from the oxyntic?
Of course, oxyntic mucosa is relatively thick, with most of its tissue made up of secretory cells, specifically parietal and chief cells. The surface here is covered by mucinous foveolar epithelium, which gives it a certain texture.
So the antral mucosa is thinner? That makes sense because it's in different regions of the stomach. But what about its composition?
Exactly. The antral mucosa is thinner, and instead of being dominated by secretory cells, its glands are mucinous. However, the surface still has that foveolar epithelium.
Got it. So both types have foveolar epithelium on top, but their underlying structures differ based on function.
And that's now one key thing to look for in the stomach is intestinal metaplasia or goblet cells. These are markers of chronic irritation.
Why are goblet cells significant? And how can you identify them?
Goblet cells are usually visible at low power, especially when using a PAS-AB stain. They appear as indigo blue bulbous cells. Their presence indicates that the stomach lining has undergone some changes due to prolonged irritation.
So identifying these goblet cells is crucial for diagnosing conditions like metaplasia or early signs of pathology.
All right, let's dive into this. When examining stomach tissue, it's crucial to remember that true goblet cells are usually scattered among non-mucinous pink absorptive cells.
Wait, so goblet cells aren't always in uniform rows? That makes sense, because normal tissues have a mix of cell types.
Exactly. A row of back-to-back tall mucinous cells, even if they're blue on PASAB staining, is unlikely to be actual intestinal metaplasia. And it's important to look for other signs like exudate or debris.
I'm a bit confused about the PAS-AB test here. Why does it matter if they're blue?
And the PAS-AB staining highlights mucinous cells, but just being blue doesn't confirm metaplasia. You need to assess the overall context, like whether there's necrosis or debris nearby. Looking at figure 3.8, these caseating granulomas in tuberculosis show necrotic debris and histiocytes. This is what we were talking about when we discussed signs of erosion or ulceration.
So if I see ragograms or neutrophils, that suggests an ulcerative process rather than just normal tissue changes?
Exactly. Always look for those clues: exudate, debris, and irregular gland morphology. They're your indicators of pathological changes. All right, let's dive into understanding how to assess inflammation in the stomach. At higher power magnification, we look at the lamina propria, where a few lymphocytes and plasma cells are normal, especially in the antrum.
So just to clarify, if I see scattered lymphocytes and plasma cells in the lamina propria of the stomach, that's considered normal, right? But what changes would indicate chronic gastritis?
Exactly. Back-to-back lymphocytes and plasma cells pushing aside or crowding the glands suggest chronic gastritis. It's about their arrangement and density.
I see in the image that there are arrows pointing to areas with dense inflammatory infiltrates. How do we differentiate between active and inactive chronic gastritis?
Great question. If you find neutrophils embedded in the surface or glandular epithelium, that indicates active inflammation. Only mononuclear cells mean it's inactive. All right, let's dive into the fascinating world of gastrointestinal pathology. Today, we're focusing on some key cellular components in the stomach and how they help us diagnose various conditions.
So, starting with eosinophils, I remember they are involved in allergies, but what does their presence mean in the stomach lining?
Great question. Eosinophils are usually part of a normal immune response. However, when you see dense sheets of them in the lamina propria, it often points to allergic or eosinophilic gastritis. And it's all about their concentration and location.
Okay, so if I'm looking at a biopsy slide and see lots of eosinophils clustered together, that could indicate an allergic reaction in the stomach.
Exactly. Now moving on to lymphocytes. You might be wondering how many we need to see before diagnosing lymphoma.
That's a bit vague in the text. And are we talking about just a few or a significant number?
It takes a lot, like extensive numbers, not just a few scattered here and there. Lymphoma is more about a proliferation that's hard to miss.
Got it. So if I see lymphocytes in the surface epithelium, what could that mean?
That's interesting. It's just extensive intraepithelial lymphocytes often suggest celiac disease or lymphocytic gastritis, colitis. It's a clue to look for other related symptoms. And when you see active chronic gastritis with lymphoid follicles. Think Helicobacter pylori. Those little rods are visible on H&E, but better seen with DiffQuick or GEMSA. All right, well, let's dive into this. When looking at the stomach under a microscope, you might come across something called H. pylori. These are bacteria that can live in the stomach, but they're not always harmful. In fact, if the organisms are sparse, they might actually be helpful.
Wait, why would bacteria ever be helpful? That seems counterintuitive.
Good question. Pylori can help reduce the acidity in the stomach, which might protect against conditions like esophageal reflux disease. But if they're too abundant, they can cause problems like gastritis or ulcers.
So we should only see them at 40 times magnification as tiny seagull-shaped rods in the pit lumens or on the surface.
Exactly. At 40 degrees, you'll spot them as small, discrete rods, mostly in the antrum, the lower part of the stomach, unless there's intestinal metaplasia, which creates a hostile environment for these bugs.
Intestinal metaplasia. I'm not entirely sure what that is. Is it when the stomach lining changes to look more like intestines?
Yes, exactly. Intestinal metaplasia is a condition where the normal cells in the stomach are replaced with cells that resemble those found in the intestines. This change can make it harder for H. pylori to survive.
Got it. So if there's no significant inflammation, we shouldn't spend too much time looking for H. pylori. But what if there's unexplained active or inactive chronic gastritis?
And that's where other conditions come into play. One possibility is inflammatory bowel disease, particularly Crohn's disease. If you find granulomas in the stomach or encounter an unexplained active chronic gastritis in a child, think of Crohn's. And
What are granulomas? Are they like little bumps under the microscope?
Yeah, granulomas are small areas of inflammation that contain immune cells. Their presence in the stomach can be a clue towards conditions like Crohn's disease. Another important point is foveolar hyperplasia, which often occurs in the antrum. This is when the cells in the stomach lining multiply, making it more susceptible to bile reflux.
Bile reflux? So that's when bile from the intestines flows back into the stomach.
Exactly. Bile can be irritating, and in cases of foveolar hyperplasia, the stomach lining is more vulnerable to this irritation. All right, let's dive into this fascinating topic. That today we're discussing how certain substances in the body can trigger specific responses in our digestive system. One such response is foveolar hyperplasia.
I'm not entirely sure what foveolar hyperplasia is. Could you explain it more?
Certainly. Foveolar hyperplasia occurs when the surface mucin cells in the stomach lining proliferate due to irritation from substances like bile or
non-steroidal anti-inflammatory drugs such as aspirin.
Okay, so these mucin cells are multiplying. What does that look like under a microscope?
Under the microscope, you'll notice that the surface has a papillary appearance, almost resembling small hills or folds. And the pits in the stomach lining take on a corkscrew profile, which is quite distinctive.
That's interesting. What happens to the mucin itself?
The mucinous cells lose their mucin content, which is normally secreted to protect the stomach lining. This loss causes the cytoplasm of these cells to become less prominent or even disappear in some cases.
I see. How does this relate to other conditions like Helicobacter pylori gastritis?
Great question. And Helicobacter pylori gastritis, especially in the antrum region, you'll observe a dense inflammatory infiltrate. This includes lymphocytes, plasma cells, and neutrophils in the lamina propria. The presence of neutrophils in the epithelium suggests an active infection. All right, let's dive into the fascinating world of gastrointestinal pathogens. In our textbook, we've discussed H. pylori organisms in chapter 3. But I want to emphasize that infections in the duodenum are quite diverse.
Wait, Professor H, is pylori is mainly associated with the stomach, right? How does it end up in the duodenum?
Great question. Pylori can indeed cause infections in the duodenum, especially in cases of gastric mucin cell metaplasia. But there are other culprits too, like Giardia.
All right. Giardia is known for being sneaky. How do we even spot it under the microscope?
Exactly. At the beginning, Giardia hides in luminal debris without causing much inflammation. If you see tiny pink fallen leaves floating outside the mucosa, take a closer look for their distinctive eyes and kite-shaped tail. All right, let's dive into this topic. So when we consider looking at chemical gastritis, one of the key features we notice is that the nuclei in the stomach lining cells become darker or more opaque. This is called hyperchromasia.
Wait, so hyperchromasia means the nuclei are more darkly stained? That makes sense because it adds to the overall darker appearance of the tissue.
Exactly. And you'll also see smooth muscle fibers proliferating and standing up between the pits in the stomach lining, which is another hallmark of chemical gastritis.
I'm trying to visualize this. So, without much inflammation and the stroma, the lamina propria looks pale and sometimes even edematous. That must make the dark nuclei really stand out.
Yes, precisely. This appearance is called chemical gastritis or chemical gastropathy, and it's incredibly common. Now, let's talk about atrophy and intestinal metaplasia. Atrophy refers to the loss of glands in the stomach lining.
So, if the glands are lost, how do we even detect that on a biopsy? It sounds challenging, especially with factors like healing ulcers or dense inflammation and complicating things.
That's exactly why assessing atrophy can be tricky. But understanding these changes is crucial for diagnosing conditions like gastritis accurately. Today, we're discussing atrophic gastritis, which is an end-stage response to severe chronic damage in the stomach. It's always accompanied by intestinal metaplasia and inflammation.
I'm a bit confused about what exactly causes this atrophy. Could you explain further?
Certainly. There are two main types. The first is multifocal atrophic gastritis, often caused by H. Pylori infection. It primarily affects the antrum and leads to gland loss in the context of active chronic gastritis and intestinal metaplasia.
So it's related to bacterial infections? What are the histopathological features we might see here?
Yes, you may observe lymphoid follicles and pit abscesses. It's filled with neutrophils. And the second type is autoimmune metaplastic atrophic gastritis, AMAG, resulting from autoimmune destruction of parietal cells in the stomach's body.
How does this differ from the first type? I'm trying to grasp the key differences.
AMAG leads to loss of oxyntic glands due to chronic inflammation and intestinal metaplasia. Unlike multifocal, which affects the antrum, both involve inflammation and metaplasia, but have different underlying causes.
So, recognizing these conditions is crucial for treatment. Thank you for clarifying.
Right. Let's dive into this. Pernicious anemia results from the loss of intrinsic factor, which leads to a deficiency in vitamin B12. This condition often stems from autoimmune gastritis, where the stomach lining is attacked by antibodies.
So the immune system mistakenly attacks the cells that produce intrinsic factor. That's why B12 isn't absorbed properly.
Exactly. In severe cases, this leads to a compensatory response where the antrum's castrin cells increase their activity, causing hypergastrinemia.
And hypergastrinemia affects other parts of the stomach, like the ECL cells. What do those do again?
Elevated gastrin levels stimulate ECL cells in the body of the stomach. These cells can proliferate and sometimes develop into microcarcinoids or tumorlets.
But in AMAG, there's no activity or lymphoid follicles. Why is that?
And in autoimmune metaplastic anemia syndrome, the stomach's body loses its secretory glands, but doesn't form metaplasia. And so you won't see the same changes as in severe autoimmune gastritis.
So when the body of the stomach becomes like the antrum due to gland atrophy, how do we tell if it's truly antralized or just atrophic?
That's a great question. It can be challenging because both conditions look similar histologically. The key is to examine the distribution of glands and any signs of metaplasia. All right, let's dive into this topic. When dealing with stomach-related conditions, a gastrin stain can be incredibly helpful. This stain specifically targets the true antrum, making it easier to identify certain pathologies.
Wait, so a gastrin stain only highlights the true antrum. How does that help in diagnosis?
Exactly. It helps differentiate between normal inflammation and more serious conditions like lymphoma. Speaking of which, let's talk about lymphomas in the stomach. Diffuse large B-cell lymphoma is the most common type, characterized by sheets of ugly single cells. Differentiating it from regular inflammation isn't too challenging, but low-grade lymphomas can be tricky.
I see. So low-grade lymphomas are more elusive. How exactly do they present?
They often masquerade as chronic inflammation, which is why figure 7.4 in your textbook is so important. It shows chemical gastritis in the antrum, where the lamina propria appears pale and sometimes edematous, making the gland nuclei stand out starkly.
So in tentacle gastritis, unlike H. Pylori infection, there's minimal inflammation in the lamina propria. That must make it harder to diagnose visually.
In our discussion on the stomach and duodenum, one key feature to look for is the corkscrew profile of hyperplastic glands. This distinctive shape is a classic indicator of certain conditions. Additionally, you'll often see thin strands of smooth muscle running between these glands.
So these corkscrew-shaped glands are significant? I'm trying to visualize what that looks like under the microscope.
All right, let's dive into this topic. When considering lymphomas in the stomach, it's important to note that most arise from chronic H. pylori gastritis.
I'm a bit confused about how exactly chronic gastritis leads to lymphoma. Could you explain that connection?
Certainly, in the sitting of chronic H, the pylori infection, the stomach's mucosal immune system becomes activated. Over time, this can lead to various changes, including the development of lymphoid tissues and, in some cases, lymphoma.
So, what specific changes do we see in the stomach when lymphoma is present?
In lymphoma, we often observe lymphoepithelial lesions. These are areas where lymphocytes seem to be eating glandular structures. Additionally, there may be sheets of mature lymphocytes.
The image shows some cells with a fried egg appearance. What does that signify?
Those are examples of mucosa-associated lymphoid tissue, multi-lymphoma, specifically the marginal zone type. These cells have small round nuclei surrounded by clear cytoplasm, giving them that distinctive appearance.
How do pathologists confirm the diagnosis of lymphoma?
Immunostains are crucial here. In malt lymphoma, most cells should be B cells, and they also stain for CD43. However, we must be careful since T cells can also stain for CD43. Using CD3 staining helps differentiate the two.
So in chronic gastritis, most lymphocytes are T cells. How does that help in diagnosis?
And so by subtracting out the background T cells, using CD3 staining, we can focus on the B cells to confirm malt lymphoma. All right, let's dive into this case of malt lymphoma. In such cases, it's crucial to recognize that the majority of the cells involved will be B cells, which we can identify using the CD20 marker.
Wait, so if most of these are B cells, why do they also stain for CD43?
Great question. CD43 is a marker that can be found on both B and T cells. However, in malt lymphoma, the key distinction is that these are B cells. So we need to focus on that positivity while mentally adjusting for any background T cells that might also stain for CD43.
Got it. So in cases like chronic gastritis, where most lymphocytes are T cells, this must influence the interpretation of CD43 staining.
Exactly. In autoimmune conditions like chronic gastritis, you often see more T cells. This is why understanding the clinical context and using additional markers like CD3 becomes so important. It helps us subtract out the background T cells and focus on the B cell population in malt lymphoma.
So to summarize, in malt lymphoma, look for B cells, CD20+, that also stain for CD43, but remember to account for T cells using other markers like CD3. And in autoimmune gastritis cases, most lymphocytes are T cells, which affects how we interpret the same markers.
All right. Let's take a look at figure 7.6 on mucosa-associated lymphoid tissue lymphoma. Here we see sheets of lymphocytes beneath the epithelial layer and penetrating into the muscularis mucosa.
So this shows lymphocyte infiltration in the mucosal layers. How does this differ from other types of lymphomas?
Good question. In malt lymphoma, lymphocytes target specific areas like mucosal tissues. Look at the inset, and it's a classic example of lymphoepithelial lesions where glands are infiltrated by lymphocytes.
I see. The residual glands are almost destroyed with pink cytoplasm islands. What do the arrowheads point to?
And those arrowheads highlight the lymphocytes that have infiltrated and destroyed the glandular tissue. And this infiltration disrupts normal gland function. All right, let's dive into this. Systemic amyloidosis often involves the gastrointestinal tract. When we look at the stomach wall under a microscope, and especially around the vessels, we see these dense, glassy pink deposits. To identify them properly, we need to use Congo red staining, or another specific amyloid marker.
So, Professor, if I understand correctly, these deposits are a key indicator of amyloidosis in the GI tract.
Exactly. Now let's talk about ulcers. An ulcer is a second full thickness defect in the epithelium down to the muscularis mucosa. On the other hand, an erosion is more superficial. Both are accompanied by fibrinopurulent exudate and granulation tissue plus reparative glands.
And wait, so what's the difference between an ulcer and an erosion again? I get confused sometimes.
Great question. An ulcer goes through the entire epithelial layer to the muscularis mucosa, while an erosion only affects a part of it. The exudate and granulation tissue help us identify these lesions under the microscope.
And what about these reparative glands? How do they look?
Reparative glands are small, angulated glands with little mucin. The lamina propria around them may show signs of fibrosis. It's important to examine the periphery of an ulcer to find its cause, like H. And pylori infection, chemical gastritis, or even adjacent cancer. I did it very part in invasive carcinoma, which can be challenging because there are all other setups, and one key feature of reparative glands is their small reactin nuclei.
I'm a bit confused about the streaming parallel arrangement. Could you explain that again?
Certainly. Reparative glands tend to align in a streaming parallel manner because they all orient towards the surface. And this orientation is crucial for their function.
That makes sense. So, if I see this arrangement under the microscope, I can suspect reparative glands.
Exactly. Now, moving on to polyps in the stomach. One common type is the fundic gland polyp, which resembles oxyntic mucosa, but with dilated glands.
How do these compare to normal oxyntic mucosa?
Fundic gland polyps have cystically dilated glands. They're often found in older individuals and can be multiple, especially in conditions like familial adenomatous polyposis.
So, they look similar but are more dilated. I should search for stomach fundic gland polyp histology to visualize this better.
Good idea. Another type is hyperplastic polyps, which are elongated or cystic foveolar pits with mild inflammation.
How do these present clinically?
They can appear as small cysts or pits. Understanding their appearance helps in diagnosis and management.
I think I need to look up stomach hyperplastic polyp images to grasp this better.
All right, let's dive into this topic. So we're discussing something called adenomas, which are essentially neoplastic and dysplastic nodules in the stomach.
Wait, I'm a bit confused. What exactly are these adenomas?
Great question. And adenomas are growth that can develop in the stomach lining. They can be of two types, gastric or intestinal. Gastric adenomas include foveolar or mucinous types, while intestinal adenomas have goblet cells similar to those found in the colon.
So they're kind of like tumors, but not necessarily cancerous.
Exactly. By definition, adenomas have at least low-grade dysplasia. This means they have the potential to become more serious, so it's crucial to study them carefully for any signs of high-grade dysplasia.
I see. So these adenomas are often found alongside other stomach issues like atrophic gastritis.
Yes, that's right. They're usually associated with surrounding stomach pathology, particularly atrophic gastritis. This condition leads to changes in the stomach lining, which can create an environment where adenomas are more likely to develop. Looking at figure 7.7, you can see how these adenomas appear in relation to surrounding stomach tissue. The glands look poorly formed and have an infiltrative quality with very little cytoplasm, making the nuclei stand out prominently.
This high NC ratio must make them look pretty concerning under the microscope.
Um, this appearance is a key indicator for pathologists to identify these changes. It's a reminder of how important it is to carefully examine such areas for any signs of high-grade dysplasia, which could indicate a higher risk of progression. All right, let's dive into the structure of the stomach. One important aspect is the arrangement of gastric glands. These small glands are similar in size and shape to other parts of the gastric mucosa, but they have a unique orientation.
Wait, so these glands are streaming toward the surface. How does that help with their function?
Exactly. And their parallel arrangement suggests a regenerative or reparative role. And this orientation allows them to efficiently contribute to the mucosal lining's repair and renewal. All right, let's dive into dysplasia and carcinoma in the stomach. By convention, a polypoid dysplastic lesion is classified as an adenoma, but if no polyp is identified, we simply grade the dysplasia.
Wait, so if there's no polyp, just grade the dysplasia? I'm a bit confused about the difference between an adenoma and grading dysplasia. Could you clarify?
Great question. If the lesion has a polypoid appearance, it's called an adenoma. But without a polyp, we assess the severity of dysplasia itself. Dysplasia in the stomach is similar to how we assess it in Barrett's esophagus.
All right. In Barrett's, intestinal metaplasia isn't considered dysplasia by itself. So, does that mean intestinal metaplasia is just an abnormal finding, but not necessarily precancerous?
Exactly. Intestinal metaplasia is indeed abnormal, but doesn't qualify as dysplasia. Now, looking at the gastric mucosa, early dysplasia resembles a tubular adenoma of the colon, blue in color with hyperchromatic nuclei and other architectural distortions.
So histologically, dysplastic nuclei have increased hyperchromasia, pleomorphism, high NC ratios, and loss of polarity. What does that look like under the microscope?
Looking at figure 7.8, you can see fundic gland polyps with oxyntic or fundic type glands. These histological changes are, early signs of dysplasia that we need to identify and monitor closely.
I think I get it now. So, grading dysplasia helps determine the risk of progression to carcinoma in situ or invasive cancer.
High-grade dysplasia is often a precursor to invasive carcinoma. When we see features like deep aberrant keratinization or single infiltrating cells, that's highly suspicious for invasion.
But wait, isn't carcinoma in situ not used in this context? Why is that?
In the stomach, we avoid using the term carcinoma in situ because it can be ambiguous. And instead, we focus on high-grade dysplasia as a definitive marker for significant risk. All right, let's talk about some important concepts in gastrointestinal pathology. When we suspect invasive carcinoma but can't prove it definitively, we often diagnose high-grade dysplasia. It's crucial to note that carcinoma in situ isn't used in this context. Is instead, high-grade dysplasia is the term we use synonymously.
Wait, so if we can't confirm invasive carcinoma, we go with high-grade dysplasia? And that makes sense. But why isn't carcinoma in situ used here?
Exactly. Carcinoma in situ refers to cancer that hasn't penetrated the basement membrane. But in the specific context of diagnosis uncertainty, high-grade dysplasia is the preferred term. It indicates a very precancerous state with a high likelihood of progression.
Got it. So, high-grade dysplasia is like a strong indicator for potential cancer. What about the types of invasive adenocarcinoma in the stomach?
Good question. In the stomach, we have two main types, intestinal type and diffuse type. The intestinal type is fairly easy to identify because it's usually associated with atrophy and intestinal metaplasia, giving it a colon cancer-like appearance.
So, if I see signs of atrophy and intestinal metaplasia, that points toward the intestinal type. What about the diffuse type?
The diffuse type is trickier. It's poorly differentiated and doesn't follow a specific pattern like the intestinal type. This makes it harder to detect. But understanding these differences is key for accurate diagnosis. Looking at figure 7.9, we see a hyperplastic polyp that resembles chemical gastritis. Notice the corkscrew glands indicated by the arrow and the hyperplastic foveolar epithelium.
I'm trying to visualize this. Could you explain what corkscrew glands look like?
Certainly. Corkscrew glands have a distinctive spiral shape due to the arrangement of their ducts, which can be seen under microscopy.
And what about hyperplastic foveolar epithelium? Is that related to the gland structure?
The foveolar epithelium is hyperplastic, meaning it's thickened, And this often occurs in response to chronic irritation or inflammation.
So this polyp might also have inflammation and intestinal metaplasia. And how does that tie in?
Yes, these conditions can coexist. Intestinal metaplasia is a change where the cells resemble those of the intestines, often due to chronic inflammation. And today we're discussing a particularly insidious type of stomach cancer, signet ring cell carcinoma. And it's called this because of its distinctive appearance under the microscope. Single vacuolated cells with displaced and indented nuclei that resemble signet rings.
Wait, could you explain what makes these cells look like signets? I'm not quite picturing it.
Absolutely. These cells have a large central vacuole filled with mucin, creating a signet ring appearance when viewed under high power magnification. They can blend into the stroma so seamlessly that they're often missed unless you carefully scan the lamina propria at 20 times.
So if I see one signet ring cell, does that mean there are many more? It seems like a sneaky way for cancer to spread.
Once you spot the first signet ring, it's crucial to examine the entire biopsy specimen thoroughly because there could be hundreds of these cells lurking in the lamina propria. This type of carcinoma is known for its infiltrative nature and can lead to a condition called linitis plastica, where the stomach becomes rigid and rubbery.
The image shows both high and low power views. In the high power view, those cells look almost like foamy macrophages. Is that why they're sometimes hard to distinguish?
Yes, precisely. Their similarity to foamy macrophages can make them tricky to identify, especially for less experienced pathologists. That's why a meticulous examination is essential. And remember, the submucosa isn't always included in biopsy specimens, so focusing on the lamina propria is key.
So to summarize, signet ring cell carcinoma is sneaky, looks like foamy macrophages, and requires a thorough high-power examination of the lamina propria. Got it.
All right, let's delve into the structures found in the submucosa. This layer is beneath the muscularis mucosa and houses several important components.
I remember the muscularis mucosa being a thin layer, but I'm a bit fuzzy on what exactly lies below it. Could you elaborate?
Certainly, below the muscularis mucosa is the submucosa, which contains some key structures. And one of them is heterotopic pancreas. This refers to nodules of pancreatic tissue found in the gastrointestinal tract.
Heterotopic pancreas? It sounds interesting. How does it function within the submucosa?
these pancreatic nodules can secrete enzymes, but since they're in the wrong place, they might cause obstruction or inflammation. Now, another significant structure is the gastrointestinal stromal tumor. These arise from Cajal cells and are spindle cell neoplasms.
Spindle cell.
Neoplasms, these are a type of cancer.
How do we determine if they're malignant?
Just indeed can be serious. They should stain for c-KIT and DOG1 proteins, as seen in figure 711. Their malignancy is assessed based on size, location, and mitotic rate.
So, larger tumors, or those located in certain areas, are more concerning. And the mitotic rate refers to how fast they're dividing.
Exactly. Now, another submucosal entity is leiomyomas, which originate from smooth muscle cells.
Leiomyomas. I remember the benign. But how do they present clinically?
They can cause symptoms like pain or obstruction. And importantly, they are the second most common spindle cell neoplasms after GISTs. Today, we're discussing different types of tumors and their characteristics. Let's start with schwannoma, a nerve sheath tumor that is the third spindle cell lesion in the submucosa. It's important to note that it stains for S100, but not c-KIT.
Wait, what exactly does staining for S100 mean? I'm a bit confused about these markers.
Great question. Staining for S100 refers to the presence of specific proteins. Schwannoma cells express S100, a protein found in neural crest cells, which explains why this marker is significant for diagnosing such tumors. All right, let's dive into this. When examining tumor cells under a microscope, it's crucial to look for specific features that help in diagnosis. In this case, we're looking at two images, and let me explain what each one shows.
In image A, the tumor cells don't have prominent signet ring features, but are still present as individual cells. What does that mean exactly?
Good question. Signet ring cells are a specific type of cancer cell, often seen in certain cancers like gastrocarcinoma. They get their name from their appearance, a large mucin vacuole pushing the nucleus to one side, making it look like a signet ring. In image A, these features aren't prominent, but the tumor cells are still present individually.
So even without the classic signet ring appearance, they're still identified as tumor cells. And how do we differentiate them from other cells in that case? And
Excellent point. And often in image B, these tumor cells in a lymph node show the characteristic single large mucin vacuoles. The key difference between signet ring cells and fat cells is the size of their nuclei. Signet ring cells have large, dark nuclei that protrude from the central vacuole, unlike fat cells, which have smaller, less prominent nuclei. Additionally, you can compare their size to lymphocyte nuclei. which are much smaller.
So, in summary, signet ring cells have large, dark nuclei and single large mucin vacuoles, making them distinct from fat cells. And even when the signet ring features aren't prominent, their presence as individual tumor cells still indicates cancer.
Exactly. This emphasizes the importance of careful examination under a microscope. The size and shape of nuclei, along with other cellular features, play a crucial role in diagnosis. Today, we're discussing duodenal biopsies and their significance in gastrointestinal pathology. The duodenum is often included in upper GI biopsies because its pathology can be continuous with the stomach.
Why are duodenal biopsies performed alongside upper GI procedures, Professor?
Duodenal biopsies are taken for several reasons. To diagnose combined gastritis and duodenitis, investigate malabsorption syndromes like celiac disease, or identify mass lesions such as gastrointestinal stromal tumors, GIS.
Can you explain more about GISTs in the duodenum, please?
GISTs are tumors that can occur in the duodenum. They often have spindle cell morphology, as seen in figure 710. These lesions may be identified during upper GI biopsies due to their location.
What does normal duodenal mucosa look like, Professor?
Normal duodenal mucosa is about 1 millimeter thick. It features marrow villi projecting above the surface and crypts between them. The epithelium here is intestinal type, containing goblet cells among absorptive cells.
So these villi and crypts are crucial for absorption. How do pathologists assess their appearance in biopsies?
Today we're diving into the fascinating world of intestinal histology. Let's start by discussing the various cells and structures you might encounter under the microscope.
So, Professor, what kinds of cells are we looking at in the lamina propria?
Great question. In the lamina propria, you'll find lymphocytes, plasma cells, and eosinophils. These are all part of the immune system, controlling the intestinal lining for pathogens.
And I remember that some lymphocytes can be found in the epithelial layer too. But you mentioned they should be rare at the tips of the villi. Why is that?
Exactly. Intraepithelial lymphocytes are indeed present, but sparse at the villi tips. This distribution helps maintain immune surveillance without disrupting the absorptive function of the villi.
Interesting. So moving deeper into the tissue, what else can we expect to see?
Under the muscularis mucosa lies a collection of mucus glands known as Brunner glands. These are particularly important in distinguishing different regions of the duodenum.
Why are they only present in the proximal duodenum and not elsewhere?
Brunner glands are specialized for secreting mucus to protect the duodenum from acidic chyme. They're absent distally because the jejunum and ileum rely more on intrinsic mucosal defense mechanisms.
That makes sense. So, when looking at a biopsy, how do we approach it?
At low power, always assess the height of the villi first. This helps determine if there's any evidence of flattening, which could indicate inflammation or malabsorption. All right, let's dive into this topic. When examining a well-oriented specimen, one key observation is the relationship between villi height and crypt depth. In an ideal case, the villi should be greater than 3 times as tall as the crypts are deep.
Wait, so if the villi aren't actually getting shorter, but rather the crypts are deepening, does that mean the total thickness of the mucosa stays the same? I'm trying to visualize this.
Exactly, it's going the villi themselves don't shorten. Instead, the crypts and surrounding mucosa become deeper. This is an important distinction because it helps us understand changes like villus blunting or atrophy, which are terms describing short and stubby villi.
So when we see shorter looking villi, it's actually due to the surrounding tissue becoming more developed. That makes sense. What should I look for in terms of epithelial changes?
Good question. And look for areas where the epithelium appears darker than the surrounding mucosa. This could suggest dysplasia. Also, don't miss any mass lesions that might be present.
And under higher magnification, what specific signs should I focus on?
At higher power, pay attention to intraepithelial lymphocytes in the tips of the villi. These could indicate celiac disease. Additionally, look for neutrophils in the epithelium or signs of gastric metaplasia, which can be seen in peptic duodenitis. Today, we're discussing gastrointestinal stromal tumors or GISTs. These tumors are important because they can appear in various forms. Let me explain.
So, Professor, what makes a GIST look different under the microscope?
GISTs often show spindle cell morphology. Imagine long, narrow cells arranged in a bundle. Sometimes you'll see occasional paranuclear vacuoles, which are small spaces near the nucleus, suggesting smooth muscle origin.
Well, I'm not sure I got that. What exactly are paranuclear vacuoles?
Paranuclear vacuoles are tiny, fluid-filled spaces near the nucleus of the cells. They can hint at a smooth muscle background, which is crucial for diagnosis.
Got it. So GIST can look like other tumors too?
Yes. They might resemble schwannomas, where nuclei line up in a row, a feature called nuclear palisading. Sometimes they even take on an epithelioid appearance with large rounded cells. So when examining the lamina propria, it's important to look for plasma cells. Their presence is crucial as their absence can indicate an immunodeficiency state.
Why are plasma cells so important in this context?
Plasma cells produce antibodies essential for immune response. Without them, the body struggles to combat infections effectively.
So If we're looking for these plasma cells under a microscope, what should we be particularly vigilant about?
You should check for parasites like Giardia and Cryptosporidium. They can easily go unnoticed, appearing as fallen leaves or dark bubbles, respectively.
I see the figure shows metaplastic changes and inflammation. How does this relate to plasma cells?
In cases of severe gastritis, acid reflux can cause duodenal inflammation. This leads to metaplasia, where duodenal cells resemble gastric ones.
The second figure
shows histiocytes and tuberculosis granulomas.
how do these relate to the earlier discussion?
Histiocytes often contain microorganisms like Mycobacterium tuberculosis, highlighting their role in immune responses. All right, let's dive into this. When we are looking at peptic duodenitis under a microscope, one of the key findings is metaplastic mucinous cells lining the villi. These cells produce mucus, and when stained with PAS/AB, they appear bright pink because of the gastric tight mucin.
Wait, so these metaplastic cells are essentially replacing the normal duodenal mucosa? How does that look under the stain?
Exactly. The PAS/AB stain highlights the mucin produced by these cells, making them stand out as pink. It's a clear indicator of metaplasia in this context. And so another important change we see is Brenner gland hyperplasia. And so these glands are normally found in the duodenum, but in this case, there's an overgrowth of them in the mucosal layer, not submucosal.
So it's a thickening of the mucosa due to more Brunner glands. How does that affect function?
And the hyperplasia can lead to the increased secretion of mucus and enzymes, contributing to inflammation. The lamina propria also shows more inflammatory cells, which is a sign of the body's response to these changes. In more severe cases, this inflammation can lead to ulcers forming in the duodenum. So also don't forget to look for pylori organisms under the microscope. They're often present in these cases.
But wait, how do we differentiate this from gastric heterotopia?
Good question. Gastric heterotopia is when you have a nodule of actual stomach tissue in the duodenum, which can look like a polyp. But unlike peptic duodenitis, it's made up of oxyntic tight glands, not foveal or mucinous epithelia. All right, let's talk about celiac disease. It's not very common, but it's something we hear a lot about ruling out these days.
What exactly is celiac disease? I'm a bit fuzzy on the details.
Celiac disease, also known as gluten-sensitive enteropathy or SPRU, is an autoimmune disorder where the body reacts to gluten, damaging the small intestine. And in advanced cases, you see a completely flattened mucosa with no villi left. The duodenum even starts to look like colon tissue.
Wait, so the villi are those tiny finger-like projections that help absorb nutrients? If they're gone, doesn't that mean the body can't absorb food properly?
The absorptive epithelium loses its brush border and becomes a flat, low cuboidal layer. This leads to malabsorption issues. Nutrients just pass through without being absorbed.
But what does it look like under the microscope? I'm trying to visualize this flattened mucosa.
It's a striking image. The villi are completely gone, giving the duodenum a colon-like appearance. But diagnosing early changes is tricky because the earliest sign might just be an increase in intraepithelial lymphocytes at the tips of what remains of the villi.
So even before the villi are flattened, there's this buildup of lymphocytes. That must be crucial for early detection.
Yes, and evaluating villus blunting can be challenging, especially with poor quality samples. But those IALs at the villi tips are a key indicator. They're often the first sign of trouble.
This is fascinating, but also a bit overwhelming. Let me try to summarize. Celiac disease damages the small intestine, flattening its lining and causing malabsorption. Early signs include increased lymphocytes in the villi, even before they're visibly blunted.
Well said. Always good to emphasize that early detection relies on spotting those IALs. It's a critical point for diagnosis and treatment. All right, let's dive into chapter 7, focusing on the stomach. And duodenum, today we're discussing, neoplasms of the duodenum, a fascinating yet complex topic. And
Neoplasms. So these are abnormal growths or tumors, right?
exactly. Now, neoplasms in the duodenum are quite rare compared to other areas like the colon or stomach. However, there are a few common types we should be aware of. Looking at figure 716, this histological slide shows a tubular adenoma in the duodenum. Notice the low-grade dysplasia with crowded and elongated nuclei, indicated by arrows. The loss of mucinous differentiation is also significant here.
Wait, so what does low-grade dysplasia mean exactly? And why is the loss of mucinous differentiation important?
Great questions. Low-grade dysplasia refers to mildly abnormal changes in the cells that aren't yet cancerous, but could potentially progress. The loss of mucinous differentiation means these cells are losing their ability to produce mucus, which is a key function of duodenal cells.
So tubular adenomas are like precancerous lesions then? And then they look different because of the nuclei and the lack of mucus.
Exactly. Tubular adenomas are one of the most common types of duodenal neoplasms. They're similar to those found in the colon, which you studied earlier.
And what about the other types mentioned? Carcinoid tumors and lymphoma. How do they factor into this?
Good point. Carcinoid tumors are another type of neoplasm, typically arising from the enterochromaffin cells in the duodenum. Lymphomas, particularly MALT type, are also seen. These are all discussed in more detail in the sections on stomach and colon.
I see. So it's important to remember that the duodenum is closely associated with both the pancreas and common bile duct. Could a tumor there be from any of those organs?
Absolutely. In adenocarcinoma in the duodenum could potentially originate from the pancreas or bile ducts, highlighting the need for thorough histopathological evaluation.
This is a bit complex, but I think I'm getting the hang of it. So, in summary, neoplasms like tubular adenomas are rare in the duodenum, but important to recognize due to their potential for malignancy.
Well said. Always remember that early detection and understanding these lesions can make a significant difference in patient outcomes. Today, we're discussing infections of the duodenum. Among these are infections caused by H. pylori, which can occur in cases of gastric Meson cell, metaplasia, giardiasis, and others.
I remember H. Pylori is linked to ulcers, but how does it affect the duodenum?
Good point. Well, H. pylori primarily affects the stomach. It can occasionally impact the duodenum as well.
What about giardia? I'd heard it's sneaky. How does that manifest in infections?
Giardia is indeed stealthy. It hides in the intestinal debris without causing inflammation. Look for tiny pink leaf-like shapes with eyes and a kite tail under the microscope.
That's fascinating. How do we differentiate it from other organisms? Well,
The diagnostic features are key pink flattened organisms resembling sloshed cells. They're usually found near the villi without much inflammation.
what about strongyloides? How does that present?
Strongyloides worms nest in duodenal crypts. Imagine a worm-like structure coiled within the crypts, which we can identify under microscopy.
And what about immunocompromised patients? How do infections like MAI present?
In such cases, you might see foamy histiocytes in the lamina propria. An AFB stain can confirm MAI, though we must also consider Whipple's disease as a differential.
So careful histopathological examination is crucial for accurate diagnosis.
When examining cases of stuffed macrophages, it's crucial to consider differential diagnoses. And one important condition is Whipple's disease characterized by TAS-positive granules within macrophages.
I've heard of cryptosporidium before, often called crypto. How does it present in the intestines?
Cryptosporidium attaches to the mucosal surface as tiny dark spheres. It's a parasite that can cause significant issues, especially in immunocompromised individuals.
Could you elaborate on celiac disease and its histopathology?
Celiac disease leads to blunted villi, causing the duodenal mucosa to resemble colon tissue. There's chronic inflammation in the lamina propria, as seen in figure 713.
Could we take a look at figure 7.13 to visualize these changes?
Let's take a look at figure 714. This image shows Giardia organisms in the small intestine. They appear as small pink flattened structures resembling sloughed cells and are loosely associated with intestinal villi.
So these Giardia organisms look like they're just shed cells because there's no inflammation around them.
Exactly, the absence of significant inflammatory response is notable. Now, let's compare this to figure 7.13 on celiac disease.
I see in figure 713 that there are normal villi and some with increased lymphocytes. What do these arrows indicate?
The arrowheads highlight intraepithelial lymphocytes, suggesting an immune response in celiac disease. Unlike Giardia, this is a significant inflammation. And today, we're discussing neoplasms of the duodenum. These are relatively rare, but there are some common types you should be aware of.
What are the most common neoplasms found in the duodenum? Well,
The most frequent ones include tubular adenomas, which you'll see in figure 7.16, carcinoid tumors, and lymphoma, typically of the MALT type.
I remember that these conditions are also discussed in the sections on the stomach and colon. Why is that?
That's because the duodenum shares similarities with both organs, especially in terms of tissue structure and types of tumors.
Could you explain what a tubular adenoma looks like under a microscope?
Certainly, tubular adenomas in the duodenum, similar to those in the colon, exhibit low-grade dysplasia with crowded and elongated nuclei. They lose mucinous differentiation, as seen in figure 7. Today we're discussing a fascinating parasite, strongyloides. These tiny worms can be found in the human digestive system, specifically in the duodenum.
Wait, Professor, could you clarify where exactly they are located?
And certainly, strongyloides larvae hatch in the small intestine and migrate through the intestinal wall into the duodenum, where they mature. Figure 715 illustrates this perfectly with arrows pointing to their nesting spots in the duodenal crypts.
So these crypts are like tiny homes for the worms? I should check out figure 7.15 to visualize this better.